Okay, we are going to get started. I will be emceeing today. Good afternoon and welcome to the Assembly of Osteopathic Graduate Medical Educators webinar series. We're pleased to have you join us for this graduate level osteopathic training series webinar on how OPP can be better integrated into clinical course material and curriculum. My name is Dr. Stephanie Zazutek. I am the Vice Chair of the ACGME Education Committee, and I will help facilitate this webinar. Before we get started, I would like to review a few housekeeping notes. This webinar is being recorded. The recording will be posted on the AOGME webpage within 7 days. All webinar participants are in listen-only mode. If you experience technical issues during the webinar, please use the chat feature and we will assist you. If you have questions for the panelists during the webinar, please feel free to submit them through the Q&A feature at any time. If time permits at the end of the webinar, they will respond to your questions. I am excited to announce that osteopathic physicians can earn up to 1 hour of AOA Category 1A CME credit for attending this webinar live. To obtain AOA CME credit, you must complete the post-webinar evaluation survey and also submit the CME attestation form to AOGME at aacom.org. The link to download the CME attestation form will be posted into the chat. Okay, we have some noted conflict of interest disclosure. As you can see, they do not have any relevant financial relations to disclose. And next, we're going to go over the objectives. So we have some three key objectives that we're going to be focusing on today, as well as all the Q&A that we're going to be receiving. So explore strategies for integrating OPP into clinical training, learn innovative and practical approaches to seamlessly incorporate OPP into residency training across various specialties and residency program structures, compare perspectives from programs with and without osteopathic recognition, gain insight into how different residency programs, both those with OR and those without OR, successfully integrate osteopathic training into their curricula, identify challenges and solutions in applying OPP clinically, understand common barriers to implementing OPP in clinical settings, and discover effective solutions to enhance osteopathic training and practice. I will now briefly introduce our panelists. We may have some panelists who are absent today or may be joining us late, but I'm going to introduce all of them. The first is Juliet Bliss. DO is Director of Osteopathic Education and Co-Association Program Director for the Northwest Washington Family Medicine Program Residency. Towns Tucker Lee Jr. DO is Program Director for the SHREC Huntsville Memorial Hospital Family Medicine Residency. Natalie Siegfried DO is Director of Osteopathic Education for the Norman Regional Emergency Medicine Residency and Oklahoma State University Emergency Medicine Residency. Stacy Nikoloff DO is Program Director for the Forest Family Medicine Residency. And Sabrina Schrader DO is the Director of Osteopathic Education for the SSM Health St. Anthony Family Medicine Residency in Oklahoma City, Oklahoma. Thank you to our panelists for joining us today and sharing your expertise. With that, I will now turn it over to you.
All right, cool. I guess I'm going to start first. I'll speak. Tucker Lee, I'm an osteopathic family medicine and sports medicine physician, currently I'm the program director for the SHREC Huntsville Memorial Hospital Family Medicine Residency through Sam Houston State University College of Osteopathic Medicine. See some of the bullet point stats that we have on our program here, 444 Family Medicine Residency, inaugural class in 2023. We are funded through the ACGME grant, and we're actually housed within the Huntsville Memorial Hospital Rural Health Clinic. We do have osteopathic recognition. I myself was actually the Director of Osteopathic Education at UNC Southeastern through Campbell University School of Osteopathic Medicine in North Carolina before I came out to Texas. And a couple of the things you see there, we're working on strengthening some of our didactic things. Currently, we've got 2 core faculty. We have a separate DOE, who's actually the chair of osteopathic medicine, Dr. Dennis Rao. Currently, we're doing quarterly didactics with the OMM department at SHSUCOM, and we've got multiple practice opportunities, including the continuity clinic, our athletic training room, didactics, and we're actually starting up our dedicated OMT clinic here in the next little bit. And then you see I put the social determinants of health, just being in an RHC, that's definitely one of the important things. And I saw that some of the questions were related more towards OMM and OPP as opposed to just OMT strictly. So look forward to discussing with what y'all have. Appreciate it.
Good afternoon, everybody. I'm very happy to be here. My name is Natalie Siegfried. I am the DOE at Norman Regional. We are an emergency medicine residency program in Norman, Oklahoma. We're a 4-year emergency medicine program, fully ACGME accredited, and we also are osteopathic recognized. We have a pretty active OPP focus. With being emergency medicine, we have to kind of do a little bit more of our training on the fly because we don't exactly know what's going to be coming in that day. So it may be more of the social aspect focused that day, or there may be more opportunities for the OMT aspect, depending on what your patient is coming in with. We do monthly OPP lectures and skills, so that could be either the OMM aspect or the OPP aspect of things. We do quarterly OPP or OMT journal club articles. And we have an elective option if you want to kind of dive a little bit more deeper into your OMM and OMT skills. So we have an OMM elective that's a 2-week or a month-long option. And we try to keep everybody up to date with our OPP with an internal site. It's kind of like an intranet site where OMT lectures, skill sets, things like that, our residents can go in and access at any point in time. And so with that, I'll go ahead and hand it over to my colleagues at Forbes.
Okay, so we may have some of our panelists that are going to be joining us late. So we're just going to continue into the Q&A session at this time with Tucker and Natalie right now, if that's okay. And I'm going to just start with one question that's a pressing question, is how do you incorporate the OPP into your curriculum when you have both DO and MD residents?
If it's okay, I'll kind of talk about that because we have begun getting an a MD student kind of every year for the past couple of years now. So we have been really trying to dive deep into that. One of the latest thing we're doing is pairing a DO resident with an MD resident. So on our skills sessions, they kind of get that extra one-on-one teaching. Also, for our MD applicants, we do, before they get started, we have kind of some questions, videos, things like that. It's kind of like a boot camp, if you will, to kind of get them acclimated with what some of the terms are and some of the basic skill set that they'll need to do to perform the OMT aspect of things. And then we'll do one-on-one sessions with myself and the MD applicants as well, kind of throughout the year, just to kind of make sure that we are progressing along. And so another thing I think that is also very helpful is that intranet channel that I mentioned has all kinds of resources available for them for their, additional one-on-one learning on top of what they get in the didactics. And then, of course, in the ER, depending on what's coming in, they're always paired with an attending, and we have a very heavy DO attending focus. So there's some additional option for the, on-shift training to kind of help make them be aware, help them with their procedures, like if a patient comes in with a headache for the suboccipital release and things like that. So that's kind of how we tackle that within my program.
Great. And Dr. Lee, would you, I see he might be on the phone right now. So Dr. Siegfried, if you have students that are coming in from 3rd and 4th year, do you just incorporate that into what you're doing already with the residents, or do you do anything different when you have the students who are not yet residents?
Yeah, so honestly, the students that we have come through are very knowledgeable, and they actually are a really big asset to our residents, helping to kind of refamiliarize them with certain techniques that maybe they have become a little rusty on. But no, we put them just right in the mix. So in the first half of every year, our monthly OMT or OPP lectures, we actually put a little bit of COMLEX questions for our interns. Our interns in December and January of every year take their COMLEX level 3. So we kind of try to incorporate that in there. And honestly, the med students are the ones who are really helping them out. They get all the questions right. But yeah, on the monthly lectures, they're just right. We try to put them right in there, right alongside. So, and with the MD med students, we kind of try to pair them with the DO resident when there's any skills sessions to kind of help introduce them to what the OPP, OMT aspect of medicine is.
Wonderful. And Dr. Lee, how do you incorporate that?
Yeah, sorry. Of course, clinic's going to call right in the middle of everything when I'm not here because that's how it goes. Yeah, I think similarly, we have third and fourth year students that come rotating through. And yeah, to me, just building on what's been said already, the thing for me is everybody who comes through as a resident, a student, whatever, MD, DO, whatever your degree may be, you should be getting at least some level of education, because that's really, to me, what part of osteopathic recognition is. We're trying to get the word out. We may not be able to make it where everybody's at the same level as, somebody who did O&M +3 or fellowship training a +1, all those kind of things. Really just trying to make it where, in my mind, where people get more comfortable assessing patients with their hands, and they're able to at least recognize that OMT may be something applicable for a particular patient, and they're at least running through that in their minds. And so that's one of the things that I like to harp on, because for me, you know, particularly in a busy family medicine, just as it is in the emergency department, it may not be the first thing on your mind. It gets really easy to get distracted by all the other things that are around you and how you've got multiple patients you're managing all at the same time. And so to me, it's one of those where if I have it where it's as part of my mindset, I should be able to take the step back and say, okay, let me think about this, how things may be able to be applied for a particular patient that's in front of me.
Great. And just to tag on to that, for patients that are outpatient versus inpatient, how does that balance change as far as incorporating OPP into patient care?
So I think I'll just kind of jump in on that aspect. For the OPP aspect for us, if they're getting admitted, they'll have a case worker, case manager who will have all the time to kind of help get them set up with, let's say they're getting admitted for an intractable migraine, getting them set up with the neurology clinic and everything that they need. But a lot of times we have a pretty large underserved population where maybe they're older and they don't have access to rides to the appointment or the money for the prescriptions for once they're getting discharged, things like that. And so case managers are really wonderful in working with us on that. In the ER, for when we have people who are going to be discharged that day, our case manager office is, right around the corner from the doc box. And I cannot tell you the number of times every single day I'm knocking on their door with whatever social aspect, my patients may need to have addressed. And so that's kind of really how we incorporate the OPP. And I feel like that's kind of something that residents don't necessarily think that how much they are using OPP in their daily practice. And so it just kind of having to give that mindful, reminder or recognition to them that every single time you are having something filled at the hospital pharmacy for our underserved patients, or every single time you're helping the nurse to facilitate med ride, or you're signing a form helping them to get their free ride back to wherever it is they're going, or setting them up with skilled nursing. Like, that's all OPP. You're doing, incorporating the mind, body, and spirit all as one, taking some of those stressors from people.
Gosh, that is a great reminder. Thank you so much, Natalie.
So
I'm just going to have to
let's
remind
welcome Dr.
myself to
Schrader.
remind
She was
them.
one of our panelists who just joined us. So we'll just pause a second, and Dr. Schrader, if you can just give us a little bit of an intro about your program and how you integrate OPP, and then we're going to jump back into how do we manage both outpatient, inpatient care, and how do we manage it for students, which was one of our questions. How do we manage students that are both DO and MD students and residents that we have on in our programs?
Okay, well, thank you for your patience. I apologize for being just such a tech goof today, but my name's Sabrina Schrader. I graduated from the Oklahoma College of Osteopathic Medicine a long time ago, and I am currently the Director of Osteopathic Education at a community-based family medicine residency program in Midtown Oklahoma City. We have 9 per year in family medicine. There are 2 other programs at our site, a transition year and a OB residency, and we are the only osteopathic recognition program at our place. We have about half of our residents are DOs. I am interested in learning how to bring MDs in, so this will be very interesting for me just as a panelist. And how much detail did you want me to go into about our program?
Just overall, how do you integrate OPP into your curriculum?
So we, we do that with education, as far as, monthly workshops that the DOs and any interested MDs come to, where we go through case-based didactics, and we each work on each other and explain how we learn things at our different schools, and just learn from each other. We as osteopathic DOs, we help the residents have a specified OMT. They call it an OMT clinic at our place, but that on Monday and Wednesday mornings, when the residents who don't do manipulation will refer their patients to us, usually for pain, but for other things as well. As the DOE, it's my goal to get my faculty who are just checking patients out in the regular clinic, where I would really like to see our residents use our principles more. And like Natalie said, to recognize as osteopathic principles just all the things we're doing for patients. But we teach our residents how to code for OMT in the clinic session, and we might go in with them and do hands-on, but we do that mostly in our dedicated OMT clinics. And then we have them do didactic presentations, second year osteopathic oriented grand rounds. And then we go over clinical within our OMT clinics, the dedicated ones. We discuss clinical questions.
Okay, great. All right, so we're going to be throwing some questions at all of the panel right now, and we're going to circle back to Dr. Lee just about integration of OMT into the inpatient care.
Yeah, the thing for me, I saw in the chat somebody had asked about an inpatient consult service. It's actually one of the things we're working on here. Our DOE is currently going to be down as program director for a new ONMM3 program. And so one of the things that we've looked at, because part of building that up is being able to have an inpatient consult service at a particular hospital. And one spot has been a little rougher, and so we're looking at the possibility for it to be up here. Smaller hospital may mean that we have to do a little less of a lift to be able to get things going with that. And then again, piggybacking on what's been said. For me, the frame of reference that I have in my mind is osteopathic principles are supposed to be like a filter. So everything that is going in and everything that is coming out passes through that filter. We should be able to process that through all of the communications and interactions that we have with whomever it may be. If it's patients, if it's family members, if it's staff members, whomever. That to me, that's the ideal. That's the way that we're trying to do things. And I think part of it is again, it's being able to meet people where they are. You know, to me, the ideal is whoever comes walking through the door, it's my job to take care of them. Whatever it is that they need, they should be in a better place for having come under my care. That's what I'm trying to impart onto the students and the residents as well, is that's kind of the crux of the matter. That's the center of OMM OPP is we are again, it's being able to recognize the situation that the patient's in currently then, and being able to lead them on the journey of improving their overall health. Yeah.
Dr. Schrader, did you want to add anything to that about an inpatient service and how do you incorporate OPP for patients who are in or outpatient as well, and that balance?
At this time, my main focus is talking with the residents on a monthly basis when I see them, or any other time I see them in clinic, and encouraging them that they are fully functioning DOs and that it is within their purview to treat any patient that they have in the hospital setting, with manipulation as one example. And then what we have in the past had an OMT treatment service, to have somebody available to see any patient at any time just tends to really overwhelm the osteopathic residents, because they're being asked to do something that other people aren't being asked to do. So I haven't quite figured out how to overcome that hurdle. And then if I'm in clinic, or my other full-time faculty are in clinic, or doing other things, you know, do we need to oversee that and all of those issues? But, you know, what I am trying to impart on all of our residents, whether they're MDs or DOs, is that, you know, the osteopathic approach, like he said, is a way of looking at patients, and how can you look at your CHF patient, or your pneumonia patient, or your patient with, you know, inflammatory bowel disease, and interact with them either by discussing their diet or putting your hands on them, calming down their nervous system with the different techniques we have for doing that, improving their lymphatic flow, you know, improving their stem cell mobilization. You know, all of those things are available with what we're taught in school, and they are qualified to do that without me overlooking and seeing. And then all I ask them to do is just write a note about it, send it to me so I can co-sign it. And then maybe if they have difficulties, or if they have something they want to accomplish that they don't feel that they themselves can accomplish, that they want to learn some new technique or way of feeling people's health or people's disease, then if I can work it in, I will go do that. So, you know, I kind of tailor what I'm teaching to what the resident or the student is ready to learn. I mean, some residents just want to do their own thing. They want to do muscle energy techniques, or they want to do BLT, or they want to do soft tissue techniques. But it's my job to just empower them to do that, and ask them why they didn't do that, or ask them what might have happened if they had done that. And so I'm just looking for more effective ways to do that, ways to get them to see that. So if anybody has a magic bullet, that'd be great.
We have a couple questions that are coming into the Q&A, into the chat, and one of them is about assessment tools and what resources do you use for integrating OPP curriculum and so forth. So do you have particular things that you use, just for assessment? Do you lean on resources to help you run the OP programs or add things? You know, what can we impart to our participants here today that if they're not doing this or new ideas, or just if they want to start adding more OPP later on, what tips do you have for them on that?
Are you talking to me now? Or just
Actually, we're going
everybody?
to go with Dr. Siegfried, and then we're going to
Okay.
do we're going to get
Go around?
everyone's
Okay.
input. Thank you so much.
Mhm.
So, okay, that's a lot. I'll try to succinctly
Resources and
answer that.
assessment. We'll leave it at those two words.
Yeah. So, we do have a form that I use for our quarterly assessment skills, and it's pretty straightforward and simple. You know, do they have a basic understanding of what the problem area is that we're assessing? You know, how to identify that. You know, can they talk me through it, and then do they look comfortable in performing it? Obviously, we want to make people better at the end of it. And so, you know, what we usually do is quarterly. Every month we have a skill set session, but at their quarterly training, it's just looking at those techniques from the previous quarter. And we have an online resource for our residency. It's not public, but they can go and they can look at, you know, what the skill that we assessed was and taught over, and they have my slide deck and everything so that they can practice. For resources, the ACOM has wonderful resources on how to incorporate your OMT and OPP. They have practice cases that you can go through. Gosh, there's a lot of resources out there. The AOA has really lovely resources as well, that you can go on their website. What I try to do is, the Journal of Osteopathic Medicine actually just published an article a month ago, I think it was, about specifically with OPP in emergency medicine. So obviously I chose that journal club article for our quarterly journal club. So I think you just kind of have to go out there and kind of look at the broad field, and then pick up what might be best for your specific specialty. And so that's what I try to do.
Great. And Dr. Lee, you mentioned that you do have a form as well, or what other assessment tools and resources do you offer at your program?
Yeah, that's just what I was replying back, that I don't know how to read. So yeah, the one that I put in the chat there, that's kind of a good patient form for me. One of the things that I tend to do on assessment, again, for me, I tend to be very kind of just pragmatic about it. So I do a lot of direct observation, particularly when I'm here in the training room. With the athletes, it's pretty easy. So I let the students do the assessment, do this, and then you're going to bring it back to me and say, well, what do you want to do about it? And usually they're going to go, I don't know, maybe some soft tissue. Great. That's a good place to start. At least you thought of something. Being able to use that, confirm their exam findings, using that kind of as a springboard to be able to say, okay, we're going to warm up with a little bit of soft tissue. Maybe we'll do some of the other bread and butter kind of OMT things. Then if we have a good response, great, good job. Congratulate them. You did what you were supposed to do. If we need to clean up a little bit more, that's when we can kind of get into some more nuanced techniques. But again, yeah, for me on the resident side, we've been able to kind of use some of the same tools that they use for the first and second year students, because now there's a bigger focus on trying to keep it going all the way through all 4 years of medical school. And so we've been able to kind of tweak a couple of things here and there. But I tend to be more pragmatic in that it's like, can you do it without hurting anybody? Great. That's a good first step. When we're able to meet that, then we can move along to the next step of, okay, we're going to work on this, this, and this. You're going to get your fundamentals right. Then we're going to be able to get into more nuanced treatment techniques.
Thank you. And Dr. Schrader, do you have anything to add for assessment and resource tools?
Um, I'm assuming by assessment, and it seemed as if you were distinguishing between assessment of osteopathic manipulative skill and ability versus applying osteopathic principles to patient care. And so with regard to the latter, I know that we, in all of our evaluations on all of our residencies, all of our rotations, as well as, clinic monitoring evaluations, there will be one or two questions that tie in with the osteopathic milestones, asking about, does the resident, if osteopathic, uh, have osteopathic observations regarding their patient's case scenario? Do they voice those? And then that would be, and I believe this came from the osteopathic recognition and uh, resources that are available on the ACGME website. There is an evaluation in there that has different things. And then does the resident do that, with a lot of help, with very little help, just being reminded, or they can do it on their own, or they can teach it, and so that assigns it a different number and then puts it into their milestones for their 6-month evaluation. So, and then as far as, we have different evaluations for different activities the residents do, like when they do their second year research and case presentation, they'll have a different evaluation, and that'll map over into, say, the milestones that have to do with that activity. And then we have one for our OMT clinics that have to do more with, do they put the patient in the right position? Do they have the right vector force? Do they apply a right amount of pressure, et cetera? So we have several different evaluations that map into the ACGME Osteopathic Recognition milestones to provide us an idea of how the resident is doing all around. I hope that answered a question.
Yes, thank you. And another question that's been coming out is more about how do you train residents for OMM documentation and billing? And just to tie on to that is, what do we need to do for our students in 3rd and 4th year before they get to residency about knowing documentation and billing? So we'll start with anyone on that.
For our aspect, we don't have anything that is, a dedicated OMT visit because they're coming into the emergency department, but we have sections. And so we have macros that we can use that will give you because for your billing, you need a dedicated osteopathic exam with your findings and then your procedure that you performed and, the outcomes, how well the patient did with it. So we have some macros for that. And for the OPP aspect, we have in our MDM a specific area for social determinants of health, which is really where a lot of our OPP. So for example, if we had discussions with case management and getting them, set up with, certain programs to help with, the financial aspect or what have you, we just really kind of give kind of targeted, detailed information onto that. And that's how we also can assess our residents, because the residents will go in and they do the charts. Of course, it's signed off by a DO attending on all of their charts, but that's how we can kind of do chart review to kind of see how they are meeting their OPP and OMM milestones. So.
Is there any additional training the students should have before they go into residency that you think would be beneficial for the clinical years or even the preclinical years?
I'm always of the opinion of the more training, the better. I do think that if they had kind of, maybe a at least half day or hour session about, how to kind of make them think about it more. And of course, they're going to learn so much of this on the fly as they're going. But, I do think just the basics of helping them to understand that, hey, even though you were, considering the OMT aspect and you kind of figured out what the cause of their, OMT concern was, or, you didn't necessarily document it in the, correct way, having your osteopathic exam. So for example, like your OA, you didn't, you said they had a headache and you were going to, you think that the cause of it was the OA, but you didn't document that what the tissue texture, restrictions were or anything like that. And so kind of just helping them to know the basics of that and helping them to know that they need to describe what they did for that. So, let's say you had a patient with a headache and you did all of the right things, but you did a suboccipital release, but you didn't describe, kind of what that procedurally was like, that does not necessarily count towards the billing aspect. I think that would be good because a lot of newer residents and a lot of med students do not think about the billing aspect of things. They're just still trying to like soak in the medicine aspect. And so I do think that that would be beneficial.
How about you, Dr. Lee? Do you have any formal training for the residents when they first start, or do you have any recommendations for anyone teaching students before they get to the program about what they need to know about documentation and billing?
Yes, I think they tend to get a fair bit on the documentation stuff. I did drop in the chat, and then Dr. James was on with the link to it as well. Every little bit helps. What I'm seeing is the students don't really get a whole lot on billing. So anything that we're able to add definitely helps. And it's just one of those skills that, sure, they may have gotten a lecture or two or had somebody pull aside and say, hey, this is the difference between a 213 and a 214. Particularly when it comes to OMT stuff, I developed a 30-minute lecture of just, these are the codes, this is how it works. So you got to do your E&M. You have to be able to have the 25 modifier because it's a separate procedure. I saw one of the questions in the chat asking about supervising if I'm actually standing there. It's one of those where that's dependent on the resident who's doing it. It's going to be different if it's a first-year resident versus if it's a third-year resident. I think that the key is, just like billing any procedure, is that you need to be readily available. So I can't go on a walk around the block while they're doing their OMT treatment, but I don't necessarily have to be standing there looking at every little thing that they're doing. So I think that's one of the important aspects on the billing as well. Just being there for the major things. So again, it's, can I confirm the exam findings? I should probably do that before they go in and treat them most of the time. That's kind of what my goal is just to be able to say, yes, we have a definitive diagnosis. Yes, the resident's competent to be able to do this procedure. And it depends on a multitude of things on an individual basis as to what level of supervision is required for the procedure to take place.
Dr. Schrader, any additional points on documentation and billing?
You had mentioned things that could happen in the third or fourth year, which might help. And, if we could revamp the what is required for osteopathic education in the student setting, my vote would be to have everybody have a 2-week or 1 month of getting their skills back. We spend our first 2 years going at least weekly and getting, several hundred hours of, hands-on training. And then we go for 2 years not doing anything. And then if you start a residency, most people just, their eyes get big and they're like, oh, I haven't done this for 2 years except to my wife or my kids. So if we want to be good Trojan horses into the allopathic world, I think we need to put more emphasis on keeping our skills up in school so that we can go into residency knowing what we're doing and not feeling so uncomfortable. As far as billing, I find that that's something that almost has to be done one-on-one while you're doing it. We have a page that we've made that kind of explains how to bill and kind of one of those little bubble things. we're having some difficulty at times getting paid for both the visit and the OMT by our Medicaid here in the state. And so they choose either one or the other. So I think probably some advocate, there's going to have to be, our organizations advocating for us again, like they did a few decades ago. And then hospital billing, I inherited an osteopathic program that we just never billed in the hospital because the GME was an MD and he just couldn't see that. And then I have not done the work to learn how to do it and what all is needed. I do know if we ever do this again, Dr. Mark Ty at OSU, Oklahoma State University in Tulsa, has been doing that for years. And so he might be a good one to provide information on how they do that. So, one of my next steps is to get back in touch with him and to get back on the train with that. But, and then I think that probably the trick is to be able to, because in the talks that I've heard about billing, your best bet on getting paid is you explain why, doing a suboccipital release with all those boggy tissue textures or whatever it is that you find and you improve it. What good is that going to do the patient, with their current problem? And so, I'm working on a set of things that they could drop downs that they can select from to be able to document that easily. You don't want to have to type that in or dictate that every time. So I don't know if that helped anybody, but.
Thank you. All right, another question that was submitted was just about barriers. So what barriers have you faced with incorporating OPP into the curriculum?
I mean, there's always, no matter what you're trying to do, there's always a level of buy-in. So getting the residents bought in to why this is important is always, going to be a barrier. And so, I think that just being consistent with talking about it while you're on shift or in didactics, or, we do dedicated OMT or OPP journal clubs, but we also have monthly just allopathic, if you will, journal clubs, and just kind of reminding them when they select an article, kind of the OPP aspect of things, just kind of being consistent with it is how I personally try to overcome that barrier.
Yeah, I agree. To me, again, it boils down to the first step for doing something is taking the first step. So take the first step. I think of course, everybody's going to have the same answers of, time and money and this, that, and the other. Again, to me, this is something that's in our toolbox as DOs and the MDs who are trained. It helps patients. So you need to be able to consider specifically OMT, OMM and OPP. Again, that could be a whole separate discussion of we should be treating people in that regard with each one of the interactions that we have. But again, for me, if I've only got a little bit of time, okay, I'll do 2 little quick treatment techniques. And the way I usually sell it to the patient, because that's one of the things too, is having patient buy-in. If I'm able to do a little something today and it makes you get a little bit better, then that seals it in my mind that this is something that may be able to help you in the future. I can send them home with a directed home exercise program, check back in a couple of weeks. We do a little bit more intensive manipulative treatment session that time. So yeah, to me, that's part of the reason I got into academics is raising awareness. It's just being able to, I don't care if you do it yourself, as long as you're aware that somebody does it, pick up the phone and get them there because you're trying to do the best you can for your patients.
If I could just quickly piggyback off of that, again, yeah, patient buy-in is another thing. But, one of the things I think that my patients have always appreciated, we see a lot of kids, especially in the wintertime, and maybe they have some drainage, or maybe they come in for, oh gosh, they come in for constipation all of the time. And you know, one of the things that I feel like the parents of the patients really appreciate is, you know, showing them, you know, these very gentle techniques that they can also go home and reproduce. You know, so doing the gall breath technique at home, you know, very gentle, lot yields very high yield results for the patient, and parents usually typically kind of like that. And I think that that's also important and pretty easy to get buy-in when you can kind of show them, you know, these are things that you can do as well at home.
Thank you.
Exactly.
Yeah, and Dr. Schrader, any barriers that you've seen or overcome to get OPP integrated?
As far as what I see stops people from applying osteopathic principles in seeing their patients is that they think they don't have enough time. But as Dr. Lee mentioned, it doesn't take much time. They have this expectation that to do OMT on somebody is going to take an extra 30 minutes, and they're going to have an OMT table, and the patient's going to have to be receptive. They're going to have to be wearing the right clothes, you know, and then helping the resident understand that just laying your hands on somebody's shoulders and talking to them about their muscle tension and about how loosening this up will help their all the different things that it'll help. I won't go into that. You're all DOs and you know, but and I'm thinking about just getting a big poster. You know, how have you touched your patient today in an osteopathic way? You know, I mean, so just to overcome that it has to be a certain way. I have to do the technique right or it won't help the patient. I think that a barrier is that they get this idea in medical school that if they don't do a technique just right, that they might hurt the patient, or that and so then if they don't remember, oh, do I put my hand here or do I put my hand here, and they think they're not going to be able to do it just right, then they won't do it at all, and they'll just move past and prescribe the amoxicillin or whatever, because they know that's one pill, you know, however many times a day. So I find the barriers have to do with thought process. I think some of those barriers could be overcome in the medical education earlier on, but once they get to me, I find that if I just talk to them about anytime you put your hands on somebody with the intention of helping them, and if you explain to them what you're doing, and if you have them sense what it is that you're feeling so that they can feel that, then you're going to start helping patients. And I have found that the people who listen to me when I say things like that are using their osteopathic skills and thought processes more often.
Okay, great. We have just a little bit of time left, but some of the questions also came down to how do you get started? If you don't really incorporate a lot of OPP into your program right now, or if you want to enhance what's already there, what are some of the tips just to get that ball rolling?
So for me, I think reaching out to somebody who has maybe a little bit more experience in that, and maybe even just flat out asking them, hey, you know, would you be willing to kind of mentor me through this process? It is also always helpful. Of course, you can always look through like the ACOM site, the AOA. There's lots of resources out there, but I think just having a person who maybe has walked that journey before you, who can help you kind of be a guide is kind of key. And whether that might be reaching out to former, you know, medical school or whomever, I think that would probably be a really good way of kind of getting started. And, you know, just poco y poco, as they say, little by little. It doesn't have to all come together immediately.
Dr. Lee?
Yeah, do something. That's better than doing nothing. That's the place to start. Is you're thinking about it, do something. I mean, that
Okay,
again,
simple as that.
Well,
that's the
what,
thing, because if you're able to show, because that's what I've been able to see in my hands is if I've got somebody who's a learner and they're like, you can't do anything with that. Do it, and then you ask the patient afterwards, how does it feel? And I actually get them, okay, repeat the exam. You tell me, how does it feel? Does it feel like I made a difference? I think it did. Patient's happy. I think it made a difference for them. Sorry that I told you I tend to be a little bit direct with those things, but yeah, do it. That's the place to start.
Just DO it, right?
Yeah.
Dr. Schrader?
well, I feel like I'm a little, if you're talking about employing, bringing osteopathic principles and practice into a residency program that doesn't already have it, then what I find is that when I read the osteopathic recognition portion of the ACGME website, every time I get a little boost of, oh, okay, this is really what I'm supposed to be doing as a director of osteopathic education. When you read the milestones. Now I know that sounds dry and boring. I'd much, and then I too like to treat patients and talk about it and things like that. But there are a lot of tools on that website which would be possible to just apply to your program immediately and utilize them if you haven't already achieved osteopathic recognition.
And I think we have time for another question here as well, is just about how to collaborate with other residency programs. So if you're specifically osteopathic focused and you have a family medicine residency, how do you do that collaboration?
I mean, I think that that's going to be different things for different programs. One thing that my program is trying to do this year is just reaching out more and having guest lecturers. So in April, we had a guest lecturer. She came in and did fascial distortion model teaching. And so I think that, we're a small community, but everybody is, I have found super welcoming and super excited to kind of reach out and do other things. And so I think just whether that's for us, we're not able to really kind of do as much like clinic sessions, which I think would be amazing if we could, but, and we can't have them necessarily come do on the job kind of training, unfortunately, but like just doing a didactic. So that's what we're trying to do is have people kind of come in at least quarterly and do, our skills session that way. And that's probably a good way to kind of get some relationships building and get started.
Any other
I was
points,
just
Dr.
going to say,
Schrader?
I was just going to say now, as we're kind of the program here that we have, we're finally getting to where we have upper levels in second and third year. And so to me, the designated osteopathic resident, well, guess what? This is part of what separates you from the education that everybody else gets. You're taking the lead on being able to do these things. You're teaching the other residents. You're kind of going to be you're the bastion. You're bringing things along for everybody else. And we're also able to kind of involve, we're looking to expand in terms of the other GME programs that we have, kind of all the way throughout the system. And that's part of what we're looking to do, is being able to have shared didactics so that we're kind of able to take this big nebulous sort of conglomeration of all of these GMEs, and we're able to kind of help unite it under one center. And so, yeah, I think that's a good way to start it. And again, to me, it's that first step is the one that's the hardest. So if you're able to just take the step and make it where, you have buy-in on the programmatic side, and eventually it's going to get to the point where you're going to have people that on the learner side, they're able to see kind of the vision that's there. Because again, to me, it's ultimately about taking care of the patients. And so this is something that we can do to help patients. And that's why it's important. And if you don't have buy-in from your learners on that, you got bigger problems.
Dr. Schrader, any words to that? We have you on mute right now.
Could you repeat the question, please?
So the question is
Like,
just about.
Well, so we're talking about collaborating with other residencies.
Yes,
Okay.
that's it. Mhm.
So, well, for example, Dr. Siegfried has, we've reached out to each other and have talked about, how we each might improve what we're doing as a residency based on maybe doing some of the things that the other is doing. So other than that, I can't think of anything else to say that hasn't already been said well.
Okay, well, it does bring us to the end of our session today. And I think just to summarize, start early in medical school with the students, enhance it for the residency programs, utilize mentors and tapping into our national resources. And I feel like, we can just do it, as as Dr. Lee said as well, right? So I just want to thank you to our panelists so much for this great discussion, to all who joined us. If you have questions, please contact us directly at aogme@aacom.org. This concludes our webinar. Thanks again to everyone who joined us, and have a great rest of your day. And I hope we did hit most of your questions, but we hope to have more of these sessions in the future as well. Thank you so much.
Thank you for the invite.